For maxillary extractions, the upper jaw of the patient should be below the height of the operator's shoulder, above the height of the operator's shoulder, at the same height of the operator's shoulder. It makes no difference whether the patient's upper jaw is in relation to the operator's shoulder. It should be at the same height of the operator's shoulder. The chair usually has to be repositioned to be satisfactory for exodontics. For mandibular extractions, the patient should be positioned so that the occlusal plane of the mandibular arch is parallel to the floor when the mouth is open. The chair should be as low as possible. For maxillary extractions, the upper jaw of the patient should be at the height of the operator's shoulder. This positions allow the upper arm to hang loosely from the shoulder girdle and obviate the fatigue associated with holding the shoulder in an unnaturally high position during the course of the day. The low positions allow the operator to bring the back and leg muscles into the operation to assist the arm. The chair can be tipped backward slightly for maxillary extractions. The fingers of the left hand for a right-handed dentist serve to retract the soft tissue, provide the operator with sensory stimuli for the detection of expansion of the alveolar plate and root movement under the plane, help guide the forceps into place of the tooth, protect teeth in the opposite jaw from accidental contact with the back of the forceps, support the mandible while performing mandibular extractions. Remember, recommended sequence of extraction: maxillary teeth before mandibular teeth, posterior teeth before anterior teeth. So maxillary teeth before mandibular teeth, or posterior teeth before anterior teeth. Which of the following are contraindications to tooth extraction? Select all that apply. Acute pericoronitis, no, that's not a contraindication. Acute apical abscess, no. End-stage renal disease, maybe. Acute infectious stomatitis. I guess acute pericoronitis is. An acute apical abscess should not be a contraindication to extraction. It has been shown that these infections can resolve very quickly when the affected tooth is removed. However, it may be difficult to extract such a tooth either because the patient is unable to open sufficiently wide enough or because adequate local anesthesia cannot be obtained. There are few true contradictions to the extraction of teeth. Note, in some instances, the patient's health patient's health may be compromised that they cannot withstand the surgical procedure. Examples of contraindications include end-stage renal disease, severe uncontrolled metabolic disease, like in uncontrolled diabetes, advanced cardiac conditions like unstable angina. Patients with leukemia and lymphoma should be treated before extracting the teeth. Patients with hemophilia or platelet disorders should be treated before extraction of teeth. Patients with a history of head and neck cancer need to be treated with care because even minor surgery can lead to osteoradionecrosis. These patients are often treated with hyperbaric oxygen therapy prior to and following extractions, 20 sessions before and 10 after. Pericoronitis, infection of the soft tissue around a partially erupted mandibular third molar. It's an example of a contraindication also. Note, this infection should be treated prior to removal of maxillary third molar. Acute infections, stomatitis, and malignant disease are relative contraindications. Treatment with IV bisphosphonates increases the risk of osteoradionecrosis of the jaw. Note, cases of excessive bleeding after dental extractions include injury to the inferior alveolar artery during extraction of a mandibular tooth, So, causes of excessive bleeding after dental extractions include injury to the inferior alveolar artery during extraction of a mandibular tooth, usually the third molar, a muscular arteriolar bleed from a flap procedure, arteriolar, or bleeding related to a patient's history, i.e., patients who are on warfarin or drugs for platelet inhibition, patients who have hemophilia or von Willebrand's disease, or who have chronic liver insufficiency. Which of the following are ways of eliminating dead space? Select all that apply. Close the wound in layers to minimize the post-operative void. Apply pressure dressings. Use drains to remove any bleeding that accumulates. Allow the void to fill with blood so that blood clot will form. Dead space in a wound is any area that remains devoid of tissue after closure of the wound. It is created by either removing tissues in the depths of the wound or by not reapproximating tissue planes during closure. Dead space is a wound or by not dead space is a wound usually fills in with blood, which creates a hematoma with a high potential for infection. Again, dead space in a wound usually fills in with blood, which creates a hematoma with a high potential for infection. Dead space in a wound usually fills in with blood, which creates a hematoma with a high potential for infection. This is more likely to happen in closed wound incisions or in an open wound that has closed over at the top too quickly, leaving a dead space open underneath. Some of these may resolve themselves, but most need to have the fluid drained, and the dead space needs to be closed, either by deep suturing or by reopening the top of the wound and packing until it heals from the bottom up. Ways in which you can eliminate dead space: close the wound in layers to minimize the postoperative void, apply pressure dressings, use drains to remove any bleeding that accumulates, place packing into the void until bleeding has stopped. Important: infections are uncommon in healthy patients. However, whenever a mucoperiosteal flap is elevated for subjugal extraction, there is a possibility for a subperiosteal abscess. Thus, all surgical flaps should be irrigated liberally prior to closing with sutures. Note: the treatment for a subperiosteal abscess is drainage of the abscess and antibiotic treatment. Which of the following is the primary direction of luxation for extracting maxillary deciduous molars? So for deciduous maxillary molars is opposite than that on the adult dentition, as opposed to the buccal direction in adults. This is because the deciduous molars are more palatally positioned and the palatal root is strong and less prone to fracture. In general, the removal of deciduous teeth is not difficult. It is facilitated by the elasticity of young bone and the resorption of root structure. Obviously, do not use cowhorn forceps for extraction of lower primary molars because the sharp beaks of these forceps could cause damage to the unerupted permanent premolar teeth. If the preoperative radiograph shows that the permanent premolar is wedged tightly between the bell-shaped roots of the primary tooth, the best treatment is to section the crown of the primary molar and remove the two portions separately. This will help in not disturbing the permanent tooth. After extraction of mandibular teeth on a child in which mandibular block was given, I always advise child not to bite his or her lip while he or she is numb. Inform parents to watch the child so this does not occur. During extraction of a maxillary third molar, you realize that tuberosity has also been extracted. What is the proper treatment in this case? Remove the tuberosity from the tooth and reimplant tuberosity? No. Smooth the sharp edges and remain in bone and suture the remaining soft tissue? Yes. A fracture of the maxillary tuberosity most commonly result from extraction of an erupted maxillary third molar, or a second molar if it happens to be the last tooth in the arch. If tuberosity is fractured but intact, it should be manually repositioned and established with sutures. The complications most often seen after extraction of a freestanding isolated maxillary molar are fracture of the tuberosity, alveolar process fracture. Important: beware of the lone molar. It is often ankylosed to the bone, Remember, the ankylosed tooth emits an atypical sharp sound on percussion. Key point to remember: tuberosity fractures may occur and should be treated at the time of surgery. If the operator is unable to do this, she or he must arrange an immediate referral. For denture construction at the correct vertical dimension, the distance from the crest of the tuberosity to the retromolar pad should equal at least 1 centimeter. If there is inadequate intermaxillary distance at the tuberosity, a tuberosity reduction can be performed to remove excess tuberosity. An elliptic incision is made over the tuberosity and carried down to bone. Again, if there is inadequate intermaxillary distance at the tuberosity, a tuberosity reduction can be performed to remove excess tuberosity. An elliptic incision is made over tuberosity and carried down to bone. This wedge is resected. The buccal and palatal tissues are undermined subperiosteally. Submucous wedges are removed from each flap and the wound is closed. This decreases the vertical and horizontal dimension of the tuberosity. Which of the following can be safely excised in preparing the edentulous mandible for dentures? Again, which of the following can be safely excised in preparing the edentulous mandible for dentures? Labial frenum, lingual frenum, mylohyoid ridge, genial tubercles, exostosis. Okay, the genial tubercles are situated on the lingual surface of the mandible at a point about midway between the superior and inferior borders. Again, the genial tubercles are situated on the lingual surface on the mandible at a point about midway between the superior and inferior borders. There are 4 of them, 2 of which are situated on each side and adjacent to the symphysis. Although usually relatively small, they may be fairly large and extend outward from the surface of the spinous process. These tubercles are the area of muscle attachment for the suprahyoid bones. Important. If the genial tubercles were removed, the tongue would be flaccid. When removing the mylohyoid ridge, be careful to protect the lingual nerve. When removing a mandibular exostosis, as a mandibular torus, it is recommended that the envelope flap design, which has no vertical components, be used. So, which of the following can be safely excised in prepping the edentulous mandibular fractures? Mandible for dentures? It can be the labial frenum, the lingual frenum, mylohyoid ridge, and exostosis.